All right, thank you guys for all the participation so far and for coming back to something I'm really, really excited about. So first, one of my favorite people in the community, who's just an incredibly passionate nurse who really goes above and beyond to take care of people, is going to give a brief introduction. And then we're going to hear from Dr. Lisa Dixon about the power of partnership on multiple levels. So I'm looking forward.
Good afternoon. Care is a very simple word that means different things to different people. And to me, as a community outreach nurse, it simply means being the voice of advocacy to people who have since lost that voice, and making sure we pool the resources that are needed to get them the care that they need and to do so correctly. It is important for us to provide care correctly to these people with complex, co-occurring medical and psychiatric disorders. And while to some people this might simply mean accompanying them to a doctor's appointment for emotional support and for reassurance, to others it actually means making several phone calls. It means accompanying them to government agencies and filling numerous forms and following up with several different offices in order to get them the services they need and deserve to get the care they desperately need. And I believe as caregivers, all we are is a voice for the people, for these people with complex medical and psychiatric disorders that need somebody to advocate for them. And if you are here wondering how we could do this, I want to say you are in luck, my friends, because here today with us is an amazing person. She is, I'll actually read because she has accomplished so much that I cannot keep all in my head. So we have here with us the director of the Center for Practice Innovation at the New York State Psychiatric Institute. She is also internationally recognized as a health services researcher and is specialized in psychotic disorders, depression, and personality disorders. She is also a professor of psychiatry at the Columbia University Medical Center and the director of the Division of Behavioral Health Services and Policy Research with the Department of Psychiatry. She has published numerous articles in peer-reviewed journals and has won some prestigious awards. She is here today to share with us the strategy to include family members in decision-making for patients with psychotic disorders and how we can partner across disciplines to influence policy. Please join me in welcoming Dr. Lisa B. Dixon.
Good afternoon, everybody. It's a pleasure to be here. I just want to, before I start, I wanted to say I got this call from this woman named Kelly Irwin.
Who the heck?
About a year, it was, I don't know, 6 months ago, 9 months ago, and I think that I got off the phone, I was like, whoa, what just happened? What just happened across that telephone? And I'm just really so excited to be a part of something that you're clearly building, and a sensibility and a knowledge and a force that is really important. And I didn't know, I've learned about this work, and I'm just very glad to be a part and hope I can contribute. When Kelly called me, I was like, well, what do you want me to say? I'm used to, I don't do research now in this specific area of cancer care and severe mental illness. I actually have touched on it in the past, but she assured me that, and helped me to figure out what to say. And again, I hope that again, sort of some of what I've been able to do in partnership with colleagues in different stakeholder groups will be helpful, and as you figure out, you collectively in the room here, what your next steps are going to be. Okay, so I think I got this right. Okay. I would say I have no disclosures. There's no pharmaceutical company that really has any interest in me. But that's not as important as the really important disclosures, which have to do with my family. I have I'm showing two pictures that I love. And I think it just sort of shows our age. It's kind of hairdos. I love it. Now, I mean, we do have little boys wearing those little suits and ties. Anyway, that's my family. There are 6 kids in my family, kind of unusual for a Jewish family from Long Island. I am her. This is me. I am, and I had a very serious case of chapped lips at that time. I don't know if you can actually see it. And you know, the reason I show this picture is because one of my brothers developed schizophrenia, and he developed schizophrenia. You know, it's always, in retrospect, it's hard to figure out when all these things happened, in spite of the fact that I do early psychosis research, and we date the onset of psychosis. Oh no, it doesn't always happen the way we tell the researchers. Anyway, my brother probably began to get sick in college. He was a really, really good student and a very kind soul, my brother. And my mother says that he took a trip to Ireland and he kind of came back different, but not so different that he actually got into medical school and began medical school. Unfortunately, I mean, and it's actually really difficult to talk about this time. He failed out the first year, and then he went back, and needless to say, I mean, my family we didn't know what was going on. We were we have like 1 million postgraduate degrees, but that didn't help us much at this time. But nobody talked to us. He managed to pass his second shot at his first year, which I find rather remarkable. Showed his fortitude. But then when he went back for the second year, he once again failed out, and then they sent him home without any information. And he spent a lot of time in his room drinking lots and lots of water until he wound up being escorted to the hospital via ambulance. So, and it was a really bad time. It was bad for everybody. It was bad for him. So it was about a sort of a 3 or 4 year process of untreated psychosis. Anyway, here's the second picture, which is actually I use to teach medical students about the disease of schizophrenia. Although I know schizophrenia is quite heterogeneous, but why I like this picture is because it's kind of a fun picture from my childhood, but also because of this image of the tickled foot. And I don't know if you saw that when you first saw the image, but the picture, but it's there. And I just think of that gesture as something that is a very intimate gesture, if you think about it. But it's something that is lost in schizophrenia. Actually, I think that kind of intimacy, it's a complex interpersonal gesture. But anyway, that's my family, and that's my disclosure. And if you had any questions about why I became a psychiatrist, there you are. Which is, it's actually interesting when you're in the middle of interviewing, and this was a long time ago, when disclosure really wasn't as acceptable. You got interpreted and analyzed, and I was like, well, if you don't want me, I'll go somewhere else, because this is who I am. So, and it has clearly informed my work, and as you'll hear. And I should just say, my 93-year-old mother still doesn't understand that people actually pay me for my opinion. And the reality is, she's almost always right. Okay, my mother. Okay. Okay, so kind of thinking, I've had a career as a clinician, a health services researcher, as a community advocate and rabble-rouser. As I kind of just try to diagram, so we have this notion of the many stakeholders in healthcare. When you start out, you just think it's about the patients and the clinicians. And then, you realize over time that it's not about that at all, or not only about that at all, that there are many, many contributors to what happens in what, should be our effort to help people. And let's see if I can make this work. So you have this kind of notion of, this was my own personal experience of disconnection, of isolation, working hard, not getting anywhere. And I know that sounds like psychiatric residency, but it's not just psychiatric residency. But then it sort of, over time, I realized that the solution, really the kind of the meta solution, there are kind of non-meta solutions, but really the meta solution is partnership. And then of course I have to go to the dictionary and look at partnership. I think most of you know what it is, but an arrangement in which parties agree to cooperate to advance their mutual interests. And again, it is a critical part of this, that everybody wins. It's a win-win. Partnership, when it's working, is a win-win. And in talking with you and getting counseled by Kelly about how to organize this, we talked about how partnership can play out in many different ways. It's not, so if you do clinical trials, that's one that you can bring partnership in on one level. If you're policy or an advocate, you can bring in partnership on another level. So there's many ways to do it. There's not one way to do it. And so what I'm going to do is just sort of reflect a little bit on my own, the things that I've had the privilege to do in my own career that have reflected or that have included partnership. So partnership, including the family caregiver support person as a partner in care, care with the caregiver involved, partnering to advance research, partnering across the healthcare system, and building a coalition to advance policy. And that's not the order in which I'm going to go, but that's kind of that's really what I'm going to be touching on. So I'm going to start with the work that I had the privilege of doing way back when in the 90s with incredible mentors, Tony Lehman and Howard Goldman, when we were got funded by the Agency for Healthcare Research and Quality, which has become the AHCPR, to do the first PORT, Patient Outcomes Research Team, in mental illness. And what PORTs were doing was actually kind of putting evidence-based practices on the map. Before that, the notion of evidence-based practices didn't roll off our tongue the way it does now. It's actually, that kind of is mind-blowing to me. But PORTs really, I think, established the primacy of evidence-based practices as important guides in our care on the map. And so we did all this in schizophrenia. What are the evidence-based practices in schizophrenia care? And we were trying to disseminate something called family psychoeducation. Let me just see what I have next. Okay, yeah. So family psychoeducation was the evidence-based practice for schizophrenia, and in spite of all these attempts to disseminate it, it just failed. I used to give this talk, when evidence-based practices fail, what next? And so we said to ourselves, this is the cartoon, according to our computer, there was nothing wrong with your car. Like, okay, we were doing the right thing. We were trying to disseminate evidence-based practices. Why was this not working, okay? And of course, this is a broken down car. There was something very broken about this initial effort to disseminate evidence-based practices. And so, again, family psychoeducation, this 9-month program where family members came in every other week for 2 or 3 hour sessions. It was an evidence-based practice with lots of data, but limited implementation, okay? And then, as we were kind of working through this challenge, we discovered this thing, family to family, which is a program of the National Alliance on Mental Illness, was being implemented all over the country, but there was no scientific evidence that it worked, okay? So, well-established, well-researched evidence-based practice, we couldn't implement it anywhere. Program that had no science, but was implemented everywhere, all right? So, got a problem here. And so I had, again, the good fortune of being in a state with a very strong NAMI affiliate in Maryland, and I got to know Joyce Burland, and Joyce is a phenomenon. You know, maybe even she's a hurricane. She is a serious hurricane. She's amazing. She created the Family to Family program, and she and I had some very, very tough, long discussions about partnering, because I felt like, you know, can we do research on family to family? And we ended up with this partnership. Okay, so this conversation, just some of the highlights of this conversation. She said, this is not a program. This is not like one of your interventions, Lisa. This is a movement. You know, studying family to family would be like studying the women's movement, okay? I was like, okay, I can't do that. I am not a sociologist. I'm just a little old services researcher, okay? The potential, this notion of a failed study, the potential, she said, once I sort of convinced her that even though it was a movement, that it was still worth studying as a program, she was like, I don't trust your methods. I don't trust your outcomes. I don't trust, I don't trust this whole randomization thing, okay? And I sort of put it together as the potential of a failed study. So I said to her, all right, you give me the outcomes. You give me the outcomes, and we will study the outcomes that you think your program produces, okay? And this was way back in the 90s. Oh my God, I have to move a lot faster, okay. So, but over the course of the conversation, she started to understand the value of this, okay? Because we were getting into this whole world of evidence-based practices, and we found a way to partner. And even around the assessments, what we did was, okay, so she named the domains, and I said, okay, well, if we're gonna measure self-efficacy, we have to use this measure, and if we're gonna measure, empowerment, we have to use this measure. She goes, I don't like those measures. Those are bad measures. I don't trust those measures. Okay, I said, all right, you make your own measures, okay? And we'll use both sets of measures, all right? And wouldn't you know it, they both were highly intercorrelated, because Joyce, turns out she was a psychologist also. So anyway, okay, so you get the idea. All right, I'm gonna really, so what did we find? We did a randomized trial. Actually, we did a whole bunch of things. We did an open trial to start with that was uncontrolled, and then we did a non-experimental but controlled trial, and then we did a randomized trial. And what do we find? Every single study found basically the same thing: improved family member functioning, reduced family member anxiety, improved emotion-focused coping, acceptance on the part of the family member, increased empowerment in the family service system and community, improved knowledge, and significantly increased positive experience of caregiving, more or less across all the studies. And not just at the end of the intervention, but 6 months later. Yeah, so. Yeah, 9 months would be, And it's interesting because, it's bringing back memories. This study, the RCT, had over 300 people enrolled. It was clearly the most important family support program in the country, and I did not get my RCT published in the American Journal of Psychiatry. It rejected it. And I looked at, I almost wish I had saved this review. What are the diagnoses of the family members? That was literally in the review that I got of this key paper, okay? They didn't like it also, the editor didn't like it because I didn't have, the control group, the group randomized to wait, I didn't make them wait 6 months so that we could do the follow-up with a true control. But I couldn't do it. This was part of my negotiation with Joyce. She's like, no, we'll ask if people are willing to wait 3 months, but we will not make them wait 9 months to get the program. So, we did not have a control group at the 9-month follow-up. Didn't get into the American Journal. Okay, but basically we had persistence of benefit across the time. And again, just to show you, this is how long it took to do this. 20 years, okay? I mean, and just slowly but surely, funding the pilots, and then, getting the NIMH trial. I mean, and this is ridiculous, and hopefully this is different now with all the different funding mechanisms, and I think much more the technology. We really didn't know what we were doing, bottom line, so it's the story of my life. Okay, so And you can see here, I mean, I think most of you in the room probably are aware of the importance of family to family and its persistence. They don't? Okay, all right. Well, so the NAMI Family to Family program is a 12-week program created and taught by family members for family members. You can be a million other things. You can have your, you can have a million other identities, but your ticket in the room is that you're a family member. And it's standardized with a train the trainer model. It's basically, delivered by volunteers, and that's kind of a bit of a controversy. Joyce is very committed to that. She thinks that people should not get paid. If you get paid to do this, it changes the dynamic. And it's all over the country and now all over the world. Well, Canada, Italy, and Mexico. I think what we're seeing, though, is that, a lot of countries have some version of this. Okay. So anyway, that's the current, I just got these numbers from NAMI. We're actually working with NAMI to create a shortened version and also one that's designed for veterans. So there's a lot of kind of spin-off work being done. Also an online version. So it keeps moving and evolving as I think the needs of the potential recipients change, right? So this was done a long time ago. It started a long time ago, and this is a debate. I mean, Joyce will say, this cannot be done online. This is a fundamental part of this that's in person, that's human. But I would put forward that's a testable hypothesis. Anyway, okay. Okay, so let's go back to, so that's family to family. That was a research partnership that really required negotiation, understanding, and I would say respect, and also like prayers. Okay, now I'm not a religious person, but I can tell you before I looked at the results of this thing, man, I was really nervous. Like when I knew that I was going to get the data, and I knew that in some ways, I mean, I had faith in the program, but it was a randomized trial, and it didn't necessarily, we didn't know what the results were going to be, right? Fortunately, it proved to be positive. I could tell you another story, but I won't. Okay, I know. So I'm looking, all right. So, okay, but let's go back. That's family to family. It's not in the system, okay? It's outside the system. It's not about patients. It's about family members. It's not delivered by clinicians. And we still have this huge need. We still have a huge need to include families as a part of and partners in care. So that issue is still there, right? And so that we have to get back to the family psychoeducation thing. And actually, I suppose one of the reasons I have this slide up here is I did want you to see that this is these treatment recommendations we did add in 2010 that this notion of family to family became like sort of an evidence-based practice. But we still needed to get back into the world of including families in care. And what you see here, this is just some data from 2013. How many individuals, this is SMI, this is SAMHSA data, 1.3% of the population of individuals with serious mental illness, 1.3% their families got family psychoeducation in the system. So that's probably an overestimate by an order of magnitude of like 1.3%. Okay, so we still have this problem, and then the question becomes, what are we going to do about it? And this is when we were starting to sort of understand the power of shared decision-making, all right? And so a colleague of mine, Shirley, who's also a daughter, her mother has a psychotic illness. And Shirley and I have been, failing miserably over the years in promoting family psychoed, and we were like, what are we doing wrong? What are we doing wrong? And we thought about all the different initiatives that we had contributed to, and we said, well, in this one, it failed, but we dealt with provider barriers. This one, it failed, and we dealt with payer barriers. We felt like we had addressed a lot of the barriers in these different implementations that we had done until we said to ourselves, oh my God, we had not dealt with family member and consumer barriers. No one, I don't think there's a single paper out there that talks about, until, some of the work that we've done, even consumer preferences for family involvement in care in SMI. It's really pretty remarkable. So we said, let's approach this very differently. Let's approach this as And we also knew, by the way, that individuals, service users, service recipients had very valid different opinions and preferences. And I said, well, if someone were to ask me, do I want my family member involved in my care? What I would say is, it depends, okay? I was like, well, this one and not that one. And, I would want to have some control over it, right? And that's perfectly reasonable. So we kind of built this thing that we initially called family member provider outreach, because the intervention was going to be delivered by someone who is a family member of a person with mental illness. We realized pretty quickly that it didn't need to be that way, that any good clinician could do this. And so we called it Reorder, Recovery-Oriented Decision-Making for Relatives Support. And the notion of it was to promote, to promote consumer recovery and optimize family involvement in care. I know I have to go faster. So what were our goals? We developed a new strategy that uses shared decision-making, giving consumers tools to make informed choices about involving their families in their care. And also then, once we kind of got past the consumer, the same thing for families. So that this was this shared decision-making approach, both for consumers and for families. Because again, if I ask my mother, she wouldn't have wanted to go to that family psychoed thing. It just didn't conform to her life needs. And so she needed to be asked too, what works for you? Assuming that my brother would have, and he would have, and he did, said it was okay. So this is what we did. We built this model, and it had two phases. It was very brief. It had a consumer phase, and basically where we started with the individual and saying, who's in your family? What are your goals? How can your family help or not help you achieve your goals? And how do you want to do it? And we worked with the consumer to make that happen. Because, if the consumer says to the family member, will you come to my session or will you be a part of this? It's very different than if the clinician does. And then we sort of did the same thing with the family member. We used motivational enhancement techniques, education and skills training. It was very, very flexible and very, very short. And this is what we did, a randomized trial of this. We actually did it in the VA. And we enrolled people who did not have their family members involved in their care, but who were willing to talk about it. Those were our enrollment criteria. And what I want you to see here is that in the reorder condition, we had quintupling of the amount of families who got connected to care. It still wasn't, it was about 50%. And in our comparison condition, which was really quite a good comparison condition, there was no change. Okay, so. That was kind of again, a family and consumer informed strategy to promote family involvement. And I should say, in that study, the patients actually had higher levels of recovery from that simple little intervention of listening to them. That's all it was, really. It was listening in a systematic way. Okay. Then the third of the four sort of stories I want to tell is, and this really isn't that much of a story, it's just showing you some tools. Okay, so the family's at the table. Now we have to make some decisions together about care. I'm involved with this every day in the early psychosis work that we do, because of course we have young people, who are in this age of transition. There's inevitably disagreement. We have, most of our families are involved in the patient's care, but there's always often disagreement about what to do next, whether to take meds, not take meds, et cetera, et cetera. So I just wanted to show you some tools. This is the Ottawa Personal Decision Guide for 2, okay? So it's, what you'll notice here is that there's this is our sense of exercises that implement shared decision-making, where there's a process where you create the team, you articulate that this is a team, the team. Without the family there, it's just the patient and the provider. With the family there, we have a team of 3, and we're going to be involved in making a decision that involves reconciling or bringing to the table your preferences and values. And this is a tool to do this. And what I want you to see here is that we have person 1 and person 2. Okay. And this is on the internet. It's the Ottawa Decision Support Tool, and it doesn't solve the problems, but it gives you a roadmap to do it, and it also validates that this is something that we should be doing, and can be doing. And again, these are screenshots of the decision support tool. and it walks you through the shared decision-making process. Which option do you prefer? What role do you prefer in making the choice? That's a whole other thing with shared decision-making, is that not everybody wants to have the same kind of role or the same level of independent decision-making. Some people want the doctor to make the decisions for them. Other people want to have more of a role in the shared decision-making, and that's a kind of a hats off to that. And again, here you go as making the decision. So I just, this is kind of the notion that we now actually have tools to bring within the clinical encounter and within the clinical universe tools to promote partnership. Okay? Okay. And this is, oh, I just love this. This is actually a tool that Pat Deegan created for our program, for our first episode program. Again, a partnership supporting tool, which the patient or the consumer creates or assigns a designated observer, someone who's going to help them as they make a decision, maybe to reduce meds or go on meds or whatever. And it's sort of saying, look, I may not be the best observer of myself at all times, or I'm a good observer of myself, but I want another observer of myself, right? And it kind of makes it official. Again, this is just a wonderful tool that grew out of Pat Deegan, who has schizophrenia and is promulgates shared decision-making out of her experience. Okay, and then my last kind of little story is RAISE, and RAISE stands for, it's first episode psychosis treatment. RAISE stands for the recovery after an initial schizophrenia episode. And I don't know how many of you are aware of this, but we are in the middle of a major transformation in the world of first episode or early psychosis care. And RAISE was sort of the thing that began it in the United States. The Recovery After an Initial Schizophrenia Episode initiative, started in 2008, seeks to fundamentally alter the trajectory and prognosis of schizophrenia through coordinated and aggressive treatment in the earliest stages of illness. And this came from NIMH. And for NIMH to put this kind of vision out there at the beginning of an initiative was very risky and very brave on their part. They weren't saying this initiative seeks to reduce the PANSS score by 3 points. Okay, this initiative, reduces the depression score. They were saying they want to change schizophrenia treatment. Okay, so this was something that already, I think, tipped their hand about what they were about here. Okay, and so they put out a request for contracts, applications, and I want you to see the statement of work. Develop, refine, deploy, and test an early intervention model that is relevant for the U.S. mental health system. Engage community treatment programs, not academic research clinics, as partners. Incorporate features for rapid dissemination and adoption and implementation in community clinics. So this is very different. This was actually an efficacy, effectiveness, and dissemination study all rolled into one. Okay? So this is what they were going after. And maybe one of the lessons here is that some entity here has to be brave and have that vision. Because if it's not articulated, then who's going to do it? You may fail, but you're probably not going to completely fail. But this really said, okay, this is what we're going for, all right? And so I don't think NIMH is the only one that can do it. I think many of us can do it. Okay, so there were these 2 studies, and I'm not going into the details of any of the studies, only to say that the studies were done. And on October 20th, 2015, the day of the release of the main study, John Kane's study, I call that the greater RAISE. I happen to be the PI on the lesser RAISE, but anyway, we were important in other ways. But the greater RAISE, October 20th, 2015, I was in Washington. Let's see if I can get the picture. Okay, we're in Washington. And you'll see John Kane, who was the principal investigator of the main RAISE study. This is Bob Heinsohn, who was the project officer at NIMH. This is Mary Gilberti, who is the executive director of NAMI. This is moi. I don't have chapped lips. This is Maggie and Maureen and Maggie. Maureen was a patient of of not the main RAISE study, our study. She was a patient of our program in Baltimore. She started out hearing voices when she was 16. She just graduated from nursing school. And Maureen is her mom. Oops, is her mom. Okay. And we were there giving a congressional briefing. That's the lesson. The rest of this stuff is, stuff. But that's the point. We were on the Hill talking to young people. They all looked like they were 12, who were working for Congress people. And you know who put this together? It was NAMI. Okay, they put this together. It was really cool. And so, John spoke about the main findings, and just basically that it worked, that their program worked, and this works all over the world. It worked in a lot of people's hands this early. And you see here again, Maggie and Maureen spoke. And one of the lessons was to do the right things at the right time in this program. And I just, this is a slide that shows you, and I want you to note that this date of this is January 17th, 2014. So this is a complicated story, and I couldn't get in on the time to get into the details, but this was when President Obama, on January 17th, 2014, President Obama signed legislation that increased money for first episode psychosis services, new money, $25 million, which grew to $50 million, for early psychosis programs in the United States, all over the country. And that 25, like I said, grew to 50. The scientific data were presented in the middle of that time frame. So there was more to it than just the science. Okay, that's, and if we have time for questions, I'll go over that. And what do you see here? It's a mind-blowing graph. New federal funding accelerates adoption of evidence-based care for first episode psychosis. This is the number of states that have first episode psychosis programs, at least one, and many have many more. We have now 22 in New York. Massachusetts, I believe, has 6 to 8, if I'm not mistaken. And so how did this happen? Okay, it happened with a vision, it happened with research, and it happened with advocacy and partnership. So again, the stories are just examples. There are other stories. Shared decision-making applies partnership at the clinical level, and partnership transforms experiments and science into real-world benefits for people in their healthcare and self-care. And I would say that it's not just experiments and science. It transforms the activity of people who are living and people who are helping those who are living with illnesses to improve the quality of healthcare and its positive impact on our lives. So thank you. So do I have time for questions? Okay.
Questions? Yes.
I wonder, how do you, if you're trying to be aggressive and intervene early on in the first episode of psychosis, how do you work within legal restrictions in given states, knowing that a lot of the patients that are in need of aggressive treatment at that period of time may be refusing it, and may be years until
Sure.
they come to terms with
So the question is, how do early psychosis programs work when many people who are at the beginning of their illness in particular, or even not so much at the beginning, aren't particularly interested in care, right? Well, and that's all about engagement, okay? So I could show you all the materials that we have for On Track New York, which is our early psychosis program, and I can tell you don't see psychosis anywhere. It's all about finding common ground. And it really is about person-centered approaches, because it's about it's about understanding how people understand what's happened to them and providing treatment that delivers care for the way how they define the problem. And we don't get everybody for sure, but there's active research on this whole notion of reducing the duration of untreated psychosis. But I mean, I've seen this over and over and over and over again, and I'm sure, I know there are folks in the room here who do this work and can probably speak to this as well. But, if the person doesn't think they have a delusion, or if they don't think hallucinations are a problem, they may think the fact that they don't have a girlfriend is a problem, or that they're failing out of school when they used to be a really good student is a problem. And so we don't force them to agree with us about what the problem is. In fact, we don't force them anything. We just try to engage them. And, I can just say, if we start to talk about partnership issues here, families, this whole process requires engaging with families as well. I mean, because the family's saying, often, although not always, I mean, this gets into cultural issues, but you'll have the family saying, like they have their way of seeing it. And then the person who's being affected directly has their way of seeing it. And so it's sort of trying to meet everybody where they are.
Yes, okay. Kelly?
Yeah. Well, so the reason that the first episode, Psychosis Story, is a good story because it involved policymakers, right? And actually now there's this really cool slide, which it's like I just couldn't use too many slides, but there's this really cool slide where it shows the contacts, the number of contacts between NIMH staff and all these different branches of government, all right? And this is a really interesting story. So, you have CMS, you have Social Security, you even have NIDA, you have, all these other alphabet soup of federal entities who are all involved in policy. So there's a lot of dialogue. It's informing people, and it's having them at the table from the beginning, because right at the beginning of the RAISE project, we had meetings where all these stakeholders came to the table, including, of course, families and consumers, but also other federal agencies, representatives from other. There wasn't that much at the state level, I have to say, if I think back about it, but this was largely a federal effort. But this slide that shows these contacts over time had an inflection point, and the inflection point was the fourth quarter of 2012, okay? What happened in the fourth quarter of 2012 was Sandy Hook, okay? So that's part of the story, and it's a difficult part of the story, because Sandy Hook focused policymakers on mental illness. And we see this, we have to deal with this again and again in our work, where the sort of the very source of stigma can allow us to recruit resources. And is that dealing with the devil in a way that is it worth it? And I don't actually know the answer to that question, and I think it's something that we probably need to understand. But the reality is, after that, there was money on the table, and they grabbed it, and that was part of what led to the increase in the mental health block grant dollars. Now, sustaining the mental health block grant dollars and growing it, and the challenge now is, and this is all I got to tell you, I'm on a phone call every other week or so with NASHBID, the National Association of Mental Health Program Directors, okay, a bunch of consultants. A person who was in charge of a managed care organization who worked with UW to get a payment code for collaborative care. His name is Henry Harbin. We're all having these meetings, and there are some folks from Ohio, my program, to try to get a code, like a HCPCS, I don't know, there's some PICS or some kind of code. I don't know exactly what it is, but it has to do with the fact that it's not paying for a single service, but it's paying for a package of services. And so that's what we're strategizing on. I think that what I see in the world now is like it's more clear the importance of having these kind of configurations, but everybody who's on this call and then some needs to be at the table to try to move this agenda. But it's advocates, policymakers, people from NGOs, clinicians, researchers, et cetera, families.
Thank you so much. I just wanted to say one thing that you said. It was in there that the most powerful intervention that led to that huge increase in family involvement or caregiver involvement, if we're thinking about community health caregivers, was just the invitation. The asking the patient,
Right, and
asking the caregiver, right?
Here, sign this. No, you're not going to sign it.
That's not a good way to ask. That's like, how you doing? Bye. Not very open.
Yeah.
No, but I thought that's so tremendously powerful. And I hope we'll have time to continue the dialogue and the breakouts. I'm sure we will. It was wonderful. It was so powerful to have you here.